Hello, this is Kathy Go, and I had to restart this recording. So this is my new recording for heart failure. So we talked about this in class, the definition of what heart failure is. It's basically the heart's inability to pump well enough to maintain perfusion and metabolic demands of the tissues and organs. It causes backup of blood flow, congestion in both the systemic and pulmonary venous circulation. It is characterized by the inability of the heart to pump more effectively and pump blood out. It is pretty darn common. So there are two types of heart failure. There's diastolic failure, which is characterized by low cardiac output, edema, and with a normal ejection fraction. And then it's systolic failure, which is characterized by impaired contractility. So in the first one, there are stiff chambers, and the heart diastolic, the heart isn't able to fill because there's a lack of compliance. In the systolic type of heart failure, the chambers are stretched, and so the heart isn't able to pump. So what causes heart failure? Anything that interferes with the heart mechanisms that regulate cardiac output. The main causes are things that directly damage the heart. Precipitating causes are those that increase the workload of ventricles, like chronic hypertension. So this is one way in which heart failure is classified. This is the New York Heart Association classification system, and it goes from no limitation all the way to severe end-stage limitation. And so why this is important is this forms the basis for some drug dosing, which we'll talk about later. This is just a reminder of how the right and left heart relate to the pulmonary and systemic circulation, and illustrates the impacts of forward and backward effects. So backward effects are characterized by buildup that because the blood can't get into the heart, and forward effects are a consequence of buildup because blood can't get out of the heart. So let's compare the types of heart failure. So there's forward failure, which is characterized by insufficient pumping, and backward failure, which is characterized by congestion of blood behind the pumping chamber. So again, blood can't get out in forward failure, and blood can't get in backward failure. So left-sided failure is a more common form of heart failure. It results from the inability of the left ventricle to empty adequately during systole or fill adequately during diastole. So the backwards effects, which result in accumulation of blood within the pulmonary circulation, pulmonary congestion, and edema. And the symptoms that go with that are dyspnea, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, respiratory crackles, hypoxemia, and high left atrial pressure and cyanosis. So this is a schematic that illustrates in left ventricular failure the backward effects and the forward effects and how they interrelate. So left heart failure, we can look at diastolic versus systolic. In systolic heart failure, that is related to contractility, and usually there's a low ejection fraction. And it's caused by impaired heart function, increased afterload, or mechanical abnormalities, and it's more common. Whereas diastolic is because the heart isn't filling properly, can't relax, and can't stretch. It's usually caused by left ventricular hypertrophy. It happens about in 20 to 40%, and of course, a person can have some of each. In right-sided failure is commonly related to pulmonary disorders. Increased pulmonary vascular resistance, like a person with COPD, for example, will result in high afterload. That's the blood going to the lungs, then to the pulmonary circulation. And so you get right ventricular hypertrophy. and then pulmonal can develop, and that leads to right ventricular failure, and that's a very common finding in people with COPD. Backward effects are caused by congestion in the systemic venous system, and that is characterized by edema, jugular venous distension, impaired mental functioning, hepatomegaly, and splenomegaly. So forward effects cause low output to the left ventricle, which leads to low cardiac output. So here's just an illustration of what a person looks like that's suffering from left and right heart failure and some of the symptoms that go with it. So in comparing left versus right, in left heart failure, blood backs up into the left atrium and the pulmonary veins. There's increased pulmonary pressure, which causes fluid leakage, which can lead to pulmonary congestion, and edema. In right heart failure, the right ventricle fails to pump effectively, which results in fluid backing up into the venous system. Fluid moves into the tissues and organs, and typically it's a result of left heart failure. Other causes include left ventricular infarction, pulmonary embolism, and cor pulmonale. So here is a schematic showing the compensatory mechanisms which would occur naturally when cardiac output is decreased. So the body perceives this decrease in cardiac output as perhaps a loss of fluid volume, and it responds thinking that it needs to increase fluid volume to respond. So if there is increased ventricular wall tension, this is one compensatory mechanism, and this is a consequence of blood building up in the heart and all the preload and afterload problems, backward and forward pressure. That increases the stretch on the heart muscle, and that leads to hypertrophy. The RAS system is responding to the decreased cardiac output, which results in decreased kidney perfusion, which triggers fluid retention, which increases preload, and preload then dumps back into the heart, and in a normal heart would increase the cardiac output. The baroreceptors trigger sympathetic nervous system activation, which then increases heart rate and contractility. And so you get increased cardiac output. So normally these mechanisms are helpful in restoring cardiac output in a normal situation, but over the long term, they're detrimental. As you can imagine, current management of heart failure is directed towards reducing the harmful consequences of these compensatory responses. And the compensatory responses include sympathetic nervous system activation, increased preload, and myocardial hypertrophy to some extent. So in the sympathetic nervous system activation, now you know about this already. This is the fight or flight response. It's triggered by a baroreceptor reflex stimulation, which detects a fall in pressure. And then the sympathetic nerves are triggered, which then result in venoconstriction. The juxtaglomerular cells release renin, so that gets the RAS cascade going. And so that results in increased sodium and water retention. And then remodeling can also occur. And that's the process of myocyte loss, hypertrophy of remaining cells, and then eventually you get fibrosis. So initially, preload increase initially is a consequence of reduced ejection fraction with a resultant increase in end systolic volume. So the decreased cardiac output to the kidney decreased cardiac to the cardiac output results in decreased glomerular filtration rate, which results in fluid conservation. Then the RAS cascade is activated, and that brings up the blood volume. And so then there's more blood dumping into the heart, which in theory at least would stretch the heart more. But in effect, over time, it results in damage to the muscle tissue and heart failure. So hypertrophy and remodeling is another response to heart failure, and that results from a chronic elevation of myocardial wall tension. That's law of Laplace. the systolic pressures in the ventricle are needed to overcome a high afterload leading to hypertrophy. And neurohormonal factors have a hypertrophic effect on the heart. And angiotensin 2 gets into the picture and is involved in remodeling. And this is also, angiotensin 2 is one of the things that's implicated in the COVID inflammatory process as well in the lung. So this is what hypertrophy looks like. You get thickened heart muscle. And so you can have a case where the heart muscle can get flabby and dilated, and that is what enlarged ventricles look like, and they just kind of get stretched out. Or you can have thickened heart muscle that is less compliant and stretchy. So counter-regulatory mechanisms continued. Nitric oxide and prostaglandin also play a role in acting on the vascular endothelium, and they relax arterial smooth muscle and result in vasodilation and decreased afterload. That's what the intent is. So let's look at the acute and chronic, the differences between acute and chronic. So acute, I think we talked about this in class, is a sudden onset, so a medical emergency, and you get this dramatic pulmonary and systemic congestion due to increased left side and right-sided filling pressures. Acute heart failure can manifest as pulmonary edema. It's a life-threatening situation, and what happens is these little alveoli get filled up with fluid so that there's no gas exchange that can happen. It's usually associated with left heart failure. So yes, left heart failure. So then one of the symptoms that you may see depend on the age. In chronic heart failure, depend on age, underlying type and extent of heart disease, and which ventricle is affected. So in chronic, this is something you've seen a lot of around the various clinical settings. So the facies mnemonic is a way to organize your memory of the symptoms. You see fatigue, decreased activity tolerance, chest congestion or cough, edema, and shortness of breath. Some other things you might see is paroxysmal nocturnal dyspnea. That's when a person just sits up suddenly in the middle of the night because they get short of breath and they feel chest pressure and they sit up to breathe, wakes them out of a dead sleep. And orthopneas, which is where somebody needs 3 or 4 pillows in order to breathe at night. So the causes, comparing the two, in acute heart failure, it's some sort of acute event triggers it, like a MI, pulmonary embolism, myocarditis, some sort of infection, postpartum cardiomyopathy. There could be a sudden worsening of CHF, acute heart transplant rejection or trauma. Chronic heart failure is due to coronary artery disease, idiopathic cardiomyopathy, peripartum cardiomyopathy also can happen, dilated cardiomyopathy, ischemic cardiomyopathy, valve disease, and then also congenital abnormalities. So the symptom differentiation. So in chronic, there's some overlap between these sets of symptoms. So there's shortness of breath in both, but in acute, it just is a dramatic worsening of shortness of breath. There's a rapid or irregular heartbeat in chronic, and you may see that in acute. In chronic, there's sort of a gradual reduced ability to exercise. In acute, you get a sudden fluid buildup. In chronic, you have a persistent cough with white or pink blood tinged phlegm. And then in acute, you might see pink foamy mucus. So it's just sort of like burbling out of their mouth. And then in chronic, you might see weight gain from fluid retention, lack of appetite and nausea, difficulty concentrating, and decreased alertness. Whereas in acute, a person will have chest pain, especially if there's a heart attack related in the process. Also, pulmonary embolism can cause pretty intense chest pain. So let's identify the assessment findings of left and right-sided failure. So in left heart failure, you might see decreased cardiac output, symptoms like fatigue, weakness, and dizziness, confusion and restlessness, oliguria during the day and nocturia at night because the fluid's not getting to the kidneys during the day when a person's up and about. When they lay down, all that venous pooling, all the circulation, all that pooling gets back into the general circulation. The person's up all night peeing. Angina, tachycardia, and palpitations. You might hear extra heart tones. You might see pallor, weak peripheral pulses, or cool extremities. There might be a hacking cough, which might be worse at night. There might be dyspnea, orthopnea, breathlessness. There might be crackles or wheezes in the lung. There might be pulmonary edema, possibly. In right failure, you might see more systemic effects like jugular venous distension, which is kind of a classic symptom, enlarged liver, distended abdomen, anorexia and nausea. A lot of times people pack their fluid around in their abdomen, so that can be, you look for swelling, but it's not there. It's in their abdomen instead. Dependent edema, then the legs and sacrum, nocturia, weight gain, increased blood pressure from excess fluid volume, or you can have decreased blood pressure when a person starts to decompensate and has poor output. So here's a mnemonic to remember the left-sided heart failure symptoms. Do check. And here's a mnemonic to remember right-hearted failure. Head. So let's describe what you do about all this. So primarily, you want to monitor the person's status and oxygenation primarily, vital signs, and urine output. You want to keep an eye on their blood pressure and pulse and their hemodynamic status. You want to make sure that they're having adequate oxygenation. If the person's really unstable, you would mechanically ventilate them. You would position them in a high Fowler's position so that all that fluid sits down in the bottom of their lung instead of up in the top so they can move more air. Oxygen therapy, physical and emotional rest, and a structured exercise program leads to better outcomes. So that cardiac rehab can be helpful for people with congestive heart failure as well, which in former days was not, it was thought that a person, once they had heart failure, that was it. But now there's an understanding that exercise can help. So here's some subjective findings. I won't read them all to you. You can look at them. But these are things that a patient might report to you. The objective things that you might see in your assessment are things like pallor or diaphoresis or brawny edema, respiratory rate and sound, breath sounds. You might note sputum color and character, heart rate and heart tones, abdominal distension and bowel tones, and changes in level of consciousness. So the interventions that are possible are sometimes there's a fluid restriction. Usually that's not needed, but in some cases it is. And typically it's less than 2 liters a day if needed. So a person who has a fluid restriction can chew on ice chips, gum, hard candy, ice pops to help thirst. Popsicles are a great intervention there. Daily weights are important. The person should weigh at the same time in the same clothing each day. So you're looking for an increase, a weight gain of 3 pounds over 2 days, or a 3 to 5 pound increase over a week. And those things should be reported. So a person is supposed to weigh themselves daily and record it and be on the lookout for these changes. So nursing interventions continued. You want to make sure the person gets oxygen. You want them to be sitting up. You want to, this is actually a repetition of what we just talked about, monitor hemodynamic status, daily weights, I&O, administer prescribed drugs, and monitor edema. So also pacing activity is important with people in this condition. Providing diversional activities can be really helpful because a person typically who is in failure isn't really able to be very active, so that is an important piece of quality of life. You want to monitor the response to activity and therapy. Collaborate with the OT and PT, reduce anxiety, evaluate the support system, and teach patients about daily weights and their diet and things like that. So the main treatment goals for heart failure are to treat the underlying causes and contributing factors, do whatever it takes to maximize cardiac output, reduce symptoms, improve ventricular function, improve quality of life, preserve target organ function, and that's really important, and improve mortality and morbidity. So especially the kidneys are an important organ to preserve, and the liver. So part of the interventions include a low sodium diet, which should be individualized and consider cultural backgrounds. And so there's a link for that. And the DASH diet is another option that's recommended. And sodium is typically restricted to 2 grams per day. Some other things that can happen are medical interventions like ultrafiltration. For patients with volume overload and that's resistant to diuretics. That's what this is here, a circulatory assist device for patients with deteriorating heart failure. And there's an intra-aortic balloon pump that helps boost cardiac output, and ventricular assist devices also can be helpful. So other medical treatments include the CardioMEM system, an implanted cardioverter defibrillator, that's pretty common. Biventricular pacing and cardio resynchronization therapy, that's something I've seen here and there. And the devices that we talk to, usually the IAPB and ventricular assist devices are just something to tide somebody over until they can get a heart transplant. Although it can be an ongoing intervention. Diuretics are important to decrease volume overload. They reduce edema, pulmonary venous pressure, and preload. They promote sodium and water excretion. There are loop diuretics, thiazide diuretics, and it's really important to monitor potassium levels, as you know, being on the lookout for hypokalemia. Other treatments are helpful in acute and end-stage management of heart failure and shortness of breath, including morphine, which helps to decrease preload and afterload and helps relieve dyspnea and anxiety and actually makes it easier to breathe. Positive inotropes, such as beta agonists like dopamine, dobutamine, norepinephrine. Phosphodiesterase inhibitors are another, like milrinone and digitalis, which is kind of fallen out of favor. RAS inhibitors are also used, like ACE inhibitors, angiotensin II receptor blockers, aldosterone antagonists, and whenever using these types of medications, you want to monitor potassium levels. Be on the lookout for hyperkalemia, especially with the aldosterone antagonists, because those are potassium-sparing diuretics, and a person can get into trouble that way. Other drugs include beta blockers, vasodilators such as nitrates, combination therapies like Bidil, positive inotropic agents like digitalis are all possible treatments for this condition. So diagnostic testing for heart failure includes these lab values. These are good things to know about. Electrolytes, BUN, and creatinine. Liver function tests, and you can see why that might be valuable because of the liver congestion. BNP is really good, or NT pro-BNP. Chest x-ray is another important helpful diagnostic to detect pulmonary congestion. Echocardiogram, ECG, and oxygen saturation are all important tools. So diagnostic studies are offered to determine and treat underlying causes, and the typical treatments are echocardiogram, which is typically done. It provides information on ejection fraction and heart valve pumping and heart chambers. You can actually kind of see what's going on. It's like an ultrasound of the heart. ECG, chest x-ray again, 6-minute walk test. The mucus scan is another really helpful imaging test. Cardiopulmonary exercise stress test, heart catheterization, and EMB. And it's really important to monitor BNP levels. Those are really a good diagnostic tool. So this is a little mnemonic to help you remember BNP. Breathing near impossible. So health promotion around this condition. So we did this. We looked at some clinical scenarios, and important health promotion concepts include interprofessional communication, identifying and treating risk factors. The main concepts around health promotion is that heart failure is a progressive disease, so it's important to establish treatment plans and quality of life goals. A person should be taught self-management tools for symptom management, such as daily weights, keeping a calendar, having a pill box to keep your medication straight, diet teaching, such as restricting salt and sometimes water, energy conservation, and maintaining support systems. So what you would teach the patient are signs and symptoms of heart failure exacerbation, so you can catch them before that person needs to go to the hospital, what to do and report, and emphasize the importance of early detection. Patients can have a positive outlook with chronic health problems if the treatment plan is followed. In terms of drug therapy, it's good to teach them about what the drugs are for, what you expect them to do, signs of toxicity, how to take a pulse is really a helpful thing to teach people that take the medications that are appropriate for this condition. And also teaching about signs and symptoms of hypo and hyperkalemia and blood pressure monitoring as needed. Also, teaching about diet. There should be a written plan. The patient should practice or learn about reading labels for sodium because it's in everything. Also knowing about daily weights and eating smaller, more frequent meals. Puts less demand on the heart. Activity and rest pattern, energy conservation, and energy efficient behaviors. Exercise training, which is cardiac rehab, which you would gradually increase over time. Avoid extremes in temperature, rest after exertion, and avoid emotional upsets. That is the end of my talk. Thank you for listening.